Bueno, creo que es un privilegio tener hoy aquí dos personalidades muy relevantes del campo de la investigación en el HIV y SIDA. En primer lugar, es un privilegio poder presentar al doctor Dan Kuritzkes. Es muy conocido de muchos de vosotros. Dan Kuritzkes es doctor en medicina, es profesor de la Escuela de Medicina de la Universidad de Harvard y actualmente es el director del Departamento de Enfermedades Infecciosas en uno de sus más importantes hospitales asociados, el Brigham and Women's Hospital. La trayectoria del doctor Kuritzkes ha cubierto un campo muy amplio y ha sido uno de los pioneros en la instauración de nuevos tratamientos, en la generación de resistencias, y en esta línea es investigador principal y coordinador de los ACTGs, ¿no? Como sabéis, uno de los grupos de trabajo en ensayos clínicos más importantes, que mantiene una actividad de más de 30 ensayos continuamente, con el reclutamiento de más de 5.000 pacientes todos los años y que en gran parte ha marcado todo el campo del tratamiento del VIH. Más recientemente, su interés se ha focalizado en las estrategias para la curación, la erradicación del VIH, y ese va a ser el motivo de su charla esta noche. So it's my privilege to introduce Dr. Kuritzkes tonight. The title of his talk will be On the Road to Cure. So thank you very much for joining us. Thank you.
Thank you very much, Professor Delgado, and thanks to the organizers for inviting me to give this plenary talk. It's really a great honor and pleasure to be here in this wonderful city. This evening, I'm going to give you a quick overview of where we stand in our efforts to find a cure for HIV. I think for this audience, it's not necessary for me to explain why we're interested in finding a cure, and I won't spend very much time talking about the mechanisms by which HIV persists, but really talk about how we're going about attempting to eradicate HIV in order to achieve either sustained remission or real cure. These are my conflicts of interest. So, by way of background, we know that substantial progress has been made in understanding mechanisms of latency, in defining the anatomic and cellular nature of the latent reservoir, understanding the genetic structure of the reservoir in terms of proviral DNA, and the contribution that clonal expansion of CD4 positive T cells makes to the maintenance of that reservoir. We've also been able to take advantage of new developments of therapeutic approaches in oncology and in inflammatory diseases that might be repurposed towards HIV cure. But despite this progress, there are ongoing controversies regarding the mechanisms of viral persistence, whether there is continuous replication or homeostatic proliferation as the means of sustaining the reservoir, and the extent to which monocyte and macrophage populations contribute to the reservoir itself. Now let me provide some definitions that will help for the rest of my talk. By the reservoir, I mean only those cells that harbor replication-competent provirus that could rekindle HIV replication or transmission. Cells that contain defective viruses are really not an important part of the reservoir and shouldn't be considered the reservoir. Latently infected cells are those cells that harbor replication-competent provirus, in which the virus is transcriptionally silent and in which viral proteins are not expressed. If a cell is transcribing RNA and making viral proteins, it's by definition not latent. Now, by cure, I mean the elimination of all replication-competent viruses and proviruses, and by remission, I mean a period, the length of which we've not yet determined, during which treatment would not be required to maintain a viremia-free state without the risk of disease progression or the occurrence of non-AIDS events or transmission to uninfected people. So this slide shows you what has become the central dogma of HIV cure, the need to, on the one hand, reactivate latent virus from cells that harbor proviral DNA, in order to make them visible and able to be eliminated by an immune system that has been reactivated or repurposed towards destroying these reactivated cells. Sometimes this is called the shock and kill, but I think reactivation and elimination is a lot less of a violent approach to thinking about this. I prefer, especially in this day and age, something a little less martial by way of analogy. So let me take you now through several of the different approaches that are being attempted. The first is stem cell transplantation, because this is the only approach that to date has resulted in cure, and it's really cure of only a single person, Timothy Ray Brown, or the Berlin patient, who is now almost 10 years since his historic bone marrow transplant with a donor who had a homozygous deletion for the CCR5 receptor, rendering the donor cells intrinsically resistant to HIV. And as you see, as you see from the, let's use the pointer here, from the time of his transplant, there was no detectable viremia, his CD4 cells recovered, and he remains essentially free of HIV. Whether this is truly a cure or is simply a very long-term remission, we don't yet know for sure. Whether this outcome can be replicated is a big question. Hero Hutter, who was the hematologist responsible for the care of Mr. Brown, published 2 years ago this summary of additional attempts, none of which was so far successful, although there are now more patients who have received transplants from CCR5 deleted patients who are still on antiretroviral therapy and whose long-term outcome we're not yet certain about. Now, we had 2 patients in Boston who received stem cell transplant from wild-type donors, and after transplantation had dramatic reductions in proviral DNA. We could not find any evidence of persisting proviral DNA even after leukapheresis and large volume blood draws doing very sensitive PCR attempts at viral outgrowth, and in one patient, even rectal biopsy. And so after a period of observation that lasted from 2 to 4 years in the different patients, thought it was appropriate to attempt a treatment interruption to see if the patients were in fact cured. And as you know, it turned out they were not actually cured, that patient A rebounded in a little bit less than a 3-month period, still much longer than you would expect for a rebound after treatment interruption. And patient B went for nearly 7 months before eventually rebounding. Now, these data fit very nicely into a model that Allison Hill, who's been working with our group and with Bob Silicano's group, has proposed, where you see the log reduction in the viral reservoir predicts the duration of remission, and our patients fit in somewhere between 100 and 1,000 days, having had somewhere between a 2 and 3 log reduction. Even the Berlin patient, though, might still, in theory, relapse if followed for 20 or 30 years. So what have we learned from stem cell transplantation? What we've learned is that it's possible to reduce substantially the reservoir of latent HIV. This reduction, we believe, most likely is mediated by immunological mechanisms such as graft versus host reaction. The reduction of the reservoir prolongs the time to rebound, but latency can be maintained even in the absence of measurable HIV-specific cellular immunity. Our 2 patients had no measurable CD4 or CD8 activity against HIV, even though they did have some persisting antibody. So the virus also clearly persists in reservoirs that are inaccessible to clinical sampling. We could not find any evidence of HIV, but that doesn't mean that HIV wasn't persistent. It clearly was persisting because the patients eventually rebounded. And reactivation of rare latently infected cells is obviously sufficient to cause virologic relapse. Well, closely related to stem cell therapy is gene therapy, because ultimately the idea would be to try and take stem cells from patients, engineer them so that they become resistant to HIV, and then reinfuse them into patients. To date, this has been done mostly with peripheral CD4 cells, not with actual stem cells, and this work from Pablo Tebas at the University of Pennsylvania shows that CD4 cells that have been genetically modified in order to carry a deletion in CCR5 can persist for many days, in this case for nearly a year, and in fact subsequent follow-up shows that they've persisted even beyond a year. And when these patients underwent a treatment interruption, at least one person appeared to spontaneously control HIV, even though the cells that had been infused did not constitute a majority of the peripheral CD4 cells. The mechanism by which this occurs is still being investigated. So what we've learned about gene editing is that it's generally been safe to date, although it's mostly been done with mature peripheral cells, not with stem cells. The genetically modified cells persist, and the HIV-resistant cells are enriched during treatment interruption. The HIV kills off the susceptible cells, and so you get more of the resistant cells. But it's been difficult to achieve consistently high proportions of gene knockouts, and it's unclear how genetically modified cells by themselves can eradicate the reservoir. The latently infected cells will remain, even though it may be hard to infect new cells. So where do we need to go with these two approaches? Clearly, the Berlin patient experience remains to be confirmed. We have to see whether this result can be replicated using genetically engineered autologous cells. We need to find out if it's sufficient to introduce a population of cells resistant to HIV, or whether gene editing has to be coupled to a strategy for eliminating latently infected cells. And we need to try to develop approaches to harnessing graft versus host reaction to make it more specific so that it can safely attack cells harboring replication-competent provirus without damaging other organs or attacking HIV uninfected cells. There's been a lot of interest in the use of latency reactivating agents to stimulate the production of virus from these latently infected cells, and drugs such as romidepsin or vorinostat, panabinostat, and more recently romidepsin have been used to transiently reactivate HIV. And even disulfiram, an old drug used for treatment of alcohol abuse, has also been shown to have some activity in re-stimulating HIV expression. But it's very clear from the in vitro work from Bob Silicano's group that even with maximum stimulation, only a very small fraction of the total replication-competent reservoir is actually re-stimulated in any given challenge. And so how are we going to re-stimulate the entire reservoir in a patient? So at current dosing regimens, latency reactivating agents are only modestly effective in reactivating the latent provirus. If maximum stimulation in vitro reactivates only a fraction of intact proviruses, reactivating the entire reservoir in vivo will clearly be a major challenge. It's highly unlikely, therefore, that reactivation alone will suffice in depleting the latent reservoir of HIV. So where are we going? We need to determine whether there are safer, more effective approaches to reactivating latent provirus. We need to understand how many cycles of reactivation will be necessary to induce the entire reservoir, and whether uninducible cells that still harbor intact proviruses are clinically significant. If you can't ever stimulate them, do we really care? But how can we prove that they're not important? What is the optimal timing of reactivating the virus versus immune interventions? The timing may differ based on whether you're giving a therapeutic vaccine or some checkpoint inhibitor or a monoclonal antibody. So turning now to some immunomodulatory approaches, such as cytokines, checkpoint inhibitors, and other immunomodulators, we know that by giving an anti-PD-L1 antibody, as was done in this pilot study by Joe Iran in the AIDS Clinical Trials Group, we can, in a small number of people, reactivate HIV-specific immune responses. This study had to be halted because of toxicity that emerged in the macaque model using the same antibody, and in fact, one of our participants developed late-onset adrenal insufficiency that might have been an autoimmune consequence of immune activation from the PD-L1 antibody. We also know from very recent publication of a study done in macaques with a monkey version of the anti-alpha-4 beta-7 monoclonal that SIV infection could be naturally controlled. These were acutely infected animals that underwent early antiretroviral treatment, followed by administration of this antibody, and then during a treatment interruption, ended up spontaneously controlling virus. As you can see more clearly here, this was the treated group, and this was the control group. This antibody is very similar to vedolizumab, which is used to treat ulcerative colitis and Crohn's disease, and there is now a pilot study underway at the NIH in chronically treated patients, and there are discussions underway to try to more precisely replicate the macaque experience in acutely infected people with HIV infection. So what have we learned from these immunomodulatory approaches? Well, there clearly are encouraging data from non-human primate studies. There have been limited human trials to date. There's some evidence for a modest impact of interferon alpha, and you'll hear more about that, I think, later this week from Luis Montaner. The toxicity profile of checkpoint inhibitors continues to evolve in the oncology setting. We've just recently learned about how these drugs can cause fatal myocarditis. And so regulatory agencies have shown considerable caution in approaching trials of these agents in healthy HIV-infected persons, and the risk-benefit of these approaches really remains to be defined. So where are we going? There's continued interest in exploring the role of immunomodulator therapies in pilot studies. It's important to explore combinations of these agents with other immunomodulatory drugs, with latency reactivating agents, and with therapeutic vaccines. But these combinations may be a double-edged sword. It's clear that there is a greater chance for efficacy, but there will also be greater chances for toxicity. So safety is going to remain the primary endpoint in the next generation of studies with these agents, and infrequent but devastating toxicities, such as myocarditis, may not be detected in early phase trials and could still be a surprise waiting us down the road. Let me turn now to therapeutic vaccines. Therapeutic vaccines have been studied for 20 or 25 years in HIV and made little progress. These are the results of one study that I was involved in through the AIDS Clinical Trials Group, a study led by Chip Schooley that used a recombinant adenovirus 5 vaccine that expressed HIV gag. It was produced by Merck, and you can see in the lower line here that during a treatment interruption after vaccination, there was just a very slight reduction in set point that was just marginally statistically significant, and there was a correlation with interferon gamma production by CD4 cells in response to HIV gag, but not by cytotoxic T cells. And most other therapeutic vaccine studies have had similarly disappointing results. So what have we learned? Nearly all of the candidate vaccines have demonstrated good immunogenicity in phase 1 and phase 2 trials, but the encouraging results seen in non-human primate studies in terms of control of viremia have generally not been replicated in humans. There have been only modest effects on post-vaccine control of viremia in human trials, and there's really been no consensus on correlates of vaccine efficacy, which has really hampered our efforts to build on prior results to move to the next best vaccine. And therefore, there's been no systematic approach for building on the results of previous studies. So what do we need to do to bring therapeutic vaccines forward? We have to define better endpoints in our clinical trials, define correlates of activity. There has to be sustained focus on the most promising candidate vaccines. In the study that I just showed you, the vaccine had expired by the time we enrolled the last patient. No more vaccine was manufactured or available for future studies. So all of that work essentially is wasted because we can't do the next study with the same vaccine. We have to start with a new vaccine. We need to define long-term objectives in the therapeutic vaccine field and develop clear go, no-go criteria so we don't waste time with ineffective vaccines and focus more closely on vaccines that show promise. There's been a lot of interest recently in the potential role of broadly neutralizing antibodies, bifunctional antibodies, and CAR T cells, cells that express recombinant receptors that redirect them to specific targets. These are data from a publication just last Thursday, jointly from the AIDS Clinical Trials Group and the NIH group under Tony Fauci, showing the failure of VRC01, the broadly neutralizing antibody, to control HIV replication after administration of several doses, even though there was a significant delay in time to rebound. So there may have been some antiviral effect of the antibody, but clearly no major effect on reservoir. And of course, the Rockefeller Group has published their work as well. So what have we learned? There are modest delays in the time to virologic rebound, but no demonstrated effect on the viral reservoir to date. Pre-existing resistant minority variants emerge at the time of rebound, selecting out those resistant variants, much like we see drug-resistant variants emerging in the setting of incomplete viral suppression. Broadly neutralizing antibody combinations will be required if we're going to maintain viral suppression, and CAR T cells directed against malignant cells, we've learned from oncology, can unleash a cytokine storm, which itself can be very harmful. So where do we need to go? We have to understand whether broadly neutralizing antibodies or bifunctional antibodies can redirect innate immunity against latently infected cells. We have to determine whether BNAbs are really targeting productively infected cells, or are they just accelerating the clearance of plasma virus by immune mechanisms through Fc receptors. Are BNAbs truly agents for cure, or are they better thought of as long-acting agents for maintenance of viral suppression? So really another form of long-acting therapy, but not curative agents. In terms of CAR T cells, we have to understand if they can be safely harnessed to eradicate the reservoir, and whether there's potential for immune-mediated encephalitis if these interventions target virus in the central nervous system. Well, what about very early treatment initiation? We know that in the Visconti cohort that very early treatment led to sustained control, at least in a small proportion of patients, perhaps 15%, by mechanisms very different than what has been observed in elite controllers. We also know from the work of Jintanat Ananwaranich in Thailand that if you treat very early at PHEBIG stage 1 or 2, that you see essentially the disappearance of integrated proviral DNA from circulating peripheral blood mononuclear cells. And we learned in perinatal infection that if you treat very early, a period of sustained remission that may last for several years is possible, as was observed when this baby was inadvertently taken off therapy when the mother stopped bringing the child back for clinic visits. But as you all know, eventually the Mississippi baby rebounded more than 2 years after treatment was first interrupted. And at the very last clinic visit, when virus was not detectable by standard means, there was a very low level of viremia detected at about 10 copies per mil done retrospectively, and some evidence that there was immune reactivation, and then subsequently the baby underwent seroconversion. This shouldn't surprise us because we know from the macaque model that even if you start treatment within 3 days of infection, you still establish the reservoir, and when treatment is eventually stopped 24 weeks later, the monkeys all rebound. Somewhat more slowly than in monkeys treated later, but they nevertheless all rebound. So early treatment is not going to be the answer. So what have we learned here? That very early initiation of treatment post-infection limits but does not prevent the seeding of the reservoir. Virologic and immunologic mechanisms likely contribute to post-treatment control of the virus, but it remains unclear how these findings can be translated to chronic infection, And we have also learned the importance of controls in treatment interruption studies, and I'll just illustrate that very quickly. So I mentioned the patients that Jintanat has accumulated with acute infection. These were patients who had later stage febic infection, stages 4 and 5, and they were treated with this mixture of a reactivating agent, an immunomodulator, and a CCR5 antagonist. And you can see there are two groups here when they did the treatment interruption. And in the blue group, although most of the patients rebounded at about the same time as the red group, there was one person who took a very long time. Now, if there were no control here, you'd say, well, look, one person had good control. Maybe we should pursue this. But that was a patient in the control arm. He didn't get the intervention. So without the control, we would have been misled. So where are we going? Acute infection is a model system that tells us what might be possible, but it's just a stepping stone towards cure. It will be important to translate successful leads into populations that started treatment during chronic established infection, who after all represent more than 99% of the 34 million people living with HIV infection. Let me say a word or two about the importance of identifying correlates and surrogate markers for HIV cure. There are now numerous interventions being investigated for HIV cure or remission, as I've just walked you through. But test of cure ultimately will require an analytic treatment interruption or a monitored treatment pause, as it's sometimes being called. Prioritizing these interventions and deciding which combinations to use would be simplified if we had a validated surrogate marker that could guide our interventions. And measuring the relative effects of candidate interventions on such a marker would really guide improvements in these approaches. Now, we know how difficult it is to find markers because, again, work from the Silicano lab has shown us that most of what we measure when we measure proviral DNA by nucleic acid testing means is detecting viruses that harbor large deletions and are mostly defective. And these defective viruses emerge very rapidly, so that even in patients treated during acute infection, only 7% of their proviruses are actually replication competent, the majority being defective. So if most of what we're measuring is garbage, we can't expect to see much change in that, which makes finding a difference in response to an intervention that much more challenging. So absent an effective intervention, validating a surrogate is going to be a major challenge, just as it's been in the vaccine world. Potent effects on markers in the peripheral blood may not reflect changes in tissue reservoir, so it may be necessary to see virus disappear from the peripheral blood, but certainly not sufficient. And changes in any one marker may explain only part of the clinical benefit of an intervention, just like change in CD4 count and decline in virus load explain only part of the benefit of antiretroviral therapy. We also have to be worried that surrogate markers may be specific to the particular intervention being administered. Antiretroviral therapy increases CD4 count, so does IL-2, but by a different mechanism, and as we've all learned, IL-2 doesn't have the same benefits on disease progression as does antiretroviral therapy. So let me conclude with just 2 more slides. First, we need to rethink our approach to treatment interruption. We've learned that, at least with careful monitoring, treatment interruption can be safe in the context of studies, but hypothetical risks persist. The risk of primary infection syndrome, the risk of transmission to sex partners and needle sharers, and the risk of reseeding the reservoir. We have to consider the relative merits of looking at time to rebound versus allowing the interruption to continue until set point is reached, to look at differences in set point. And we have to consider the ethics of doing a treatment interruption in control participants. When is it appropriate to include controls? And what if a placebo is unavailable so the participants know that they didn't get the intervention? Will they still undergo the interruption? And what will be criteria for resuming ART? So let me leave you then with some unanswered questions. We need to define what is the minimum clinically acceptable duration of drug-free remission. If we're not going to get to cure itself, how long should a remission last in order to be worth the effort? Are remission or cure sufficient to return the pro-inflammatory state to normal so we don't see the risk for end organ disease? Will remission or cure reduce the risk of these non-AIDS events, or will that risk persist? How can we determine the effect of transmission of remission or cure on the risk of transmission, would you not treat a pregnant woman who had been cured of HIV and risk transmission from undetected virus to her baby? And at what point can we equate sustained remission to cure? When does remission become cure? And that, I think, is really the million-dollar question here. So with that, let me thank you for your attention and just acknowledge some of the people in my group who've contributed to all this work. Thank you.